Hi, everybody. My name is Chris Buresh, and I am going to be talking to you today about opioid use disorder in adolescents. I appreciate you taking the time to listen. Up front, I should just let you know I have some disclosures. I don't think any of them really relate to the work that we're talking about today, um, but I am on a telebuprenorphine grant, and I will be talking about buprenorphine being used off-label. That the FDA has approved it for ages 16 and over, and I think it's fine to use it at lower ages, that down to age 13. Um, and so the things that we're going to talk about today is we'll talk a little bit about the epidemiology of opioid use and overdose deaths, because you can't have one of these talks without mentioning that. We'll talk a little bit about why kids end up using opioids, and then medications for opioid use disorder, or MOUD, in children, and then how to talk to kids and their families about MOUD to help them get on it. And I'm hoping by the end of today, you'll feel a little bit more comfortable with the idea of using buprenorphine and addressing some different aspects of opioid use disorder in adolescents. And so to start out with, there was a study that just came out last year looking at overdose mortality among adolescents. And you can see there's been a tremendous spike since 2019, mostly due to fentanyl and other illicit synthetics. And this is just in the adolescent population. There's been a similar looking trend in adults across the US. And I think when you look jurisdiction by jurisdiction, I know certainly here in King County, Washington, we've seen the same trend. We've had I think 22 adolescents overdose per year for the last couple of years. And in the state of Washington last year, we had 41 kids die of an overdose. And so this is something that's very much here, it's very much happening, and is very much preventable. So why are kids using drugs? Really, the two big reasons are for coping and sensation seeking. And so, sensation seeking certainly is, I just wonder what it feels like. I'm bored. I want to give it a shot. My friends are using, I'll try. And also this sense that, when you're a teenager, you're basically bulletproof and nothing bad can happen to you. That only happens to other people. There's also this idea of coping, and I think this is what drives a lot of use, is as a way to deal with stress and anxiety, or unmet expectations, depression, and then again, that feeling of isolation. And that certainly got a lot worse during the COVID pandemic, and I think helped fuel some of the use of fentanyl among this population. And so when we talk about opioid use disorder, really this is a chronic disease that occurs along a spectrum, just like diabetes or hypertension, right? I've got mild hypertension. I take a very low dose of an ACE inhibitor, and so I'm kind of towards the left-hand side of the screen. But people can have really bad hypertension. I think my mom's on like 4 different antihypertensive medicines, right? And opioid use disorder is kind of the same way. People can move back and forth along the spectrum as they move throughout their life. And so there's kind of casual or non-problematic use. I would say there's not really, when it comes to opioids, at least any beneficial use for illicit fentanyls. Certainly there's medical use of opioids for pain control, but yeah, so there's casual, non-problematic use. There's problematic use, and then there's chronic dependence. And I would say even people that use it in a very casual way and maybe don't suffer from withdrawal when they use it are still very much at risk. And we'll touch on that a little bit later on. Adolescents are particularly vulnerable to this just because of the way that their brains are wired. And this is a biological phenomenon. It's not a personality flaw. It's just that their reward center starts to mature relatively early on, right? So when you're 5 and you're supposed to get an immunization, the doctor's like, well, I'll give you a sticker if you take this shot. And you're like, that sounds great. But as you get older, uh, you start to be able to discriminate between sort of different levels of reward, and suddenly a sticker may not seem like quite enough to get you to take that shot. And so, I think adolescents are primed to seek out rewards and dopamine and that sort of excitement. However, the prefrontal cortex isn't really mature yet, right? The prefrontal cortex is a part of your brain that is involved in sort of executive function, so planning, kind of calculating the risks and the benefits, and some more higher order thinking. And that part of the brain just isn't quite there yet. And so there's this point as the brain develops where you're sort of all about chasing the thrills and not about thinking about the risks. And again, that's just biologically driven. And so that sensation seeking and coping stuff, really, there's no brakes on those impulses. So we know that the younger you are when you start using drugs or alcohol, the more likely you are to become addicted and to have problematic use. And we think that the kids that become addicted much faster. And in fact, there's this phenomenon called rapid onset opioid use disorder that just wasn't a thing prior to illicit fentanyls. And whereas it takes somebody who's using heroin often months to years to get addicted to it, people who use fentanyl because of its pharmacokinetics, because it's very kind of rapid onset, and then it leaves the brain very quickly and redistributes elsewhere in the body. You get the high very, very quickly, and then it goes away very quickly. And that really predisposes you to this rapid onset opioid use disorder that develops and over sometimes just over a couple of uses or a few weeks. And so we mentioned some of the things that make adolescents a little bit more vulnerable. In addition, adolescents are more likely to start using drugs with fentanyl, right? So I think a lot of folks from previous eras really would rather use heroin or some other drug, but adolescents are really more likely to seek out fentanyl because it's cheap, it's available, they're familiar with it. And instead of trying to avoid it like a lot of others do. Adolescents are a lot more likely to use alone and not to use in a social setting, which is particularly problematic because of fentanyl's potency and its tendency to make you stop breathing. They're way less likely to get advice on how to use drugs safely from a reputable source, right? It's almost all sort of TikTok or social media, as opposed to, say, a syringe service program or something like that. Adolescents are the age group that is least likely to get naloxone in the event of an overdose. And we'll talk about naloxone in a minute, but that's the overdose reversal drug. And so when they looked at a giant study across 38 states, adolescents were the least likely to get naloxone, but they were almost always the most likely to die when other people were around. And adolescents are a lot less likely to be able to get treatment. Part of that is geographic, right? There's not a lot of treatment places that will see adolescents or people that aren't quite adults. Part of that is just logistical, right? A lot of times they don't have their own car or their own transportation. They have to rely on other people to get them around. They also, maybe they're in school full time. Hopefully they're in school full time. They may have a part-time job. They may have other activities that they're trying to juggle. And then so much of that has to do with stigma. And stigma probably is the thing that kills more people from overdose than anything else. And that's, adolescents, but really everybody. People who use drugs and who are addicted to opioids often don't feel good about it. They're not proud of that fact. And I think they're on high alert for any source of judgment or negative feelings from other people around their drug use. And because it's so hard for adolescents to get themselves to treatment, and because adolescents, again, that's just sort of when you are neurobiologically primed to be strengthening social connections outside of your house and your immediate family, that stigma just carries so much more weight during the adolescent time period. You're so much more worried about what other people think of you than you are later on in life. And so stigma is a tremendous problem. So here's this spectrum of use again. And I wanted to bring this up again because it turns out if you look at all the adolescents that have died over the past couple of years, most of them weren't on the right-hand side of the spectrum, right? Only about a third of the teens that have died had a history of problematic use. So, which tells me that many of the teens who die of an overdose are just dipping their toe in the water, right? They're just starting to experiment with fentanyl. Many of them, it's their first or second time using. I know personally, some of the people that I've reversed, it's their very first time using or their second time using. And they haven't been identified as someone who has problematic use or opioid use disorder. So there's really no kind of safe way to use fentanyl. And I think this is the reason that really everybody in the community needs to be prepared to address this and to talk about it. And so when you look at the way that we've historically treated opioid use disorder in the emergency department, when someone would come in with withdrawal, we usually took one of two tactics in the emergency department. We would give them, a dose of something if they promised to never come back again and darken our doorway, or we'd kind of wait them out in the emergency department and wait for them to go on withdrawal and just leave because they're so miserable. And neither one of those are very patient-centered ways of addressing a problem. And I think still today, even though we have some amazing new tools to address opioid use disorder, we still don't give this the same the kind of attention or treat it with the same kind of urgency that we should. And so if you look at, this is a big study, almost 12,000 people from Massachusetts, but I'd say this study has been replicated in Ontario and a bunch of other places with the same results. So if you look at these giant groups of people, of everybody who showed up in the emergency department with a non-fatal overdose, 5%, almost 6% of them were dead within a year. And most of that death happened in the first month after their emergency department visit, which is crazy to me, right? At 5.5% mortality rate at the children's hospital I work in, that means these are the kids in the emergency department that are the most likely to die. But if you look at, but we don't really treat it that way, right? I mean, if you think of other things with comparable mortality rates, if someone had an MI and we got them to the cath lab right away, their mortality rate is 7% in 1 year. And we train for this all the time, right? Somebody comes in with chest pain and there's a whole cascade of events that happen, right? Cardiologists get paged, the cath lab gets warmed up. There's an EKG that happens automatically. We put aspirin in their mouth without even thinking about it. All of these things happen almost reflexively. And yet people have the same mortality as someone who almost died of an overdose. And so we need to be treating this as a serious medical problem. So just to underscore this point, this is a graph. This is an old study. I think it was done in Sweden, where they put people on medications for opioid use disorder, and then half of them they transitioned to a placebo, and half of them they kept on buprenorphine. And if you look at how many people stayed in treatment, the control group, none of them did, right? None of them made it past 2 months. But the people on buprenorphine, almost all of them stayed engaged in treatment. And people that stay engaged in treatment stay alive. And to underscore that point, 20% of the people that were in the control group died within the first 2 months. So I want to talk just a little bit about some of these different drugs. So full agonist medications are, fentanyl is a full agonist medication, opioids a full agonist medication. These are things that attach to the mu-opioid receptor in your brain and turn it on all the way. And so methadone is an example of that. Methadone is different than some of the other ones because this is a long-acting medication. It kind of stays active for about 24 hours. So it doesn't have the fast, like I feel great and then I feel terrible that fentanyl has. Buprenorphine is different because it's a partial agonist. So it binds to the same receptor, the mu receptor in the brain, but it only turns it on about 40%, right? So it's kind of like a dimmer switch. And so one of the reasons that buprenorphine is so great is that it binds very, very tightly to that receptor. And so I'll show you some data in just a second. If you have a good dose of buprenorphine on board, the receptors are all occupied. And so even if you were to take a dangerous dose of fentanyl, you wouldn't stop breathing. Buprenorphine, because it activates the receptor only part of the way, really does a great job of kind of cutting out cravings so that people aren't feeling like they need to find more medications. And I think its real benefit is that it takes care of withdrawal symptoms. And so people that are on Suboxone, they're not feeling sick all the time. They feel really pretty good and they can manage their lives. And then the other medication on here is naloxone, which is an antagonist, right? So that also binds to the receptor very, very tightly and will displace the agonist. And so this is the medication that when somebody's overdosing and not breathing, if you give them naloxone, they'll start breathing again. And I would just put in a plug here, and I'll repeat this later, that really everybody should have naloxone. If you're a healthcare provider, just like everybody should know how to do CPR, everybody should have naloxone and know how to use it. And honestly, if you ask me, everybody in the community should have it. The last overdose that I reversed outside of the hospital was right outside of our ice cream shop. And luckily, we had naloxone on hand. So everybody should have this. Everybody should know how to use it. Okay. So this is some science. So everybody knows if you take too much fentanyl, you will stop breathing. And so this is, they gave, I don't know how they did this study, but they gave some healthy volunteers a whole lot of fentanyl to see how it would affect their breathing. You can see that there's this dose response curve where the more fentanyl you get, the lower your ventilation goes until eventually it reaches zero, which is not survivable. Um, if you give people buprenorphine, you can see that you can give them sort of infinity doses of buprenorphine, at least up to 8 micrograms per kilo, and they will continue to breathe. And so it's really hard to hurt people with buprenorphine. I would say this is for adults. You can actually, small children can overdose on buprenorphine, but adults and adult-sized people can tolerate huge doses of buprenorphine without stopping breathing. And so the magic comes when you combine the two. So on the left is giving people giant doses of fentanyl without any buprenorphine, and you can see that they stop breathing. And to be fair, these are super pharmacologic doses, right? I mean, pain doses of fentanyl are 25 to 50 micrograms, and they started out with 250. But that's not an unreasonable amount for someone to be taking recreationally at all. And so you can see that as your dose of fentanyl escalates, your breathing drops until it hits zero. Now, if you give somebody buprenorphine and then you give them higher and higher and higher doses of fentanyl, they'll continue to breathe the whole way through. And I think that's one of the real beauties of buprenorphine. In fact, when you give people buprenorphine or methadone, really, it decreases their chances of dying from an overdose by almost half. And so when you look at that and you stack that up against other medications that we use pretty routinely to try and keep people alive, aspirin is one of the most effective interventions we have for people that are having an MI, but you would have to give 42 people aspirin to save one life. You'd have to do a coronary bypass for 250 people to save one life, but you only have to prescribe buprenorphine 3 times to save one person from dying. And so this is, similar to the other study I showed you. This is looking at adolescents and whether they got, referral to sort of counseling and behavioral health services or whether they got medication. And you can see that people that just had the referral to behavioral health services, they really didn't stay engaged in treatment at very high rates, right? By 1 year out, only about 15% of them, 12, 15% were still engaged in care. But if they got medication, almost 3 times as many of them were still engaged in care. And so medication keeps people engaged, and engagement keeps people alive. And so I want to address a couple of myths about drug use. I think people often think that folks who use drugs don't really care about their health, that they just are there to get high and damn the consequences. They think that people who use drugs lie about their pain in order to get more drugs. I've heard people say, these folks need to hit rock bottom before they're going to get better. You have to let them go. And if you're providing compassionate care, if you're giving them medications, if you're, helping them out, all you're doing is enabling their habit. I hear people say that people, before you're going to do anything like get them set up with counseling or get them on medications, that they need to stop using, which is just sort of like a catch-22. Because many times people are using because they don't have enough services. And then the big one that I hear is that medications for opioid use disorder, like buprenorphine, like methadone, that's not really treatment. It's just a crutch. It's just another way for them to get high, and you're not really addressing the underlying problem. And it's just not true. In fact, as I mentioned before, using those medications cuts their mortality by 50% and helps them move more towards the left-hand side of the spectrum, right? Like not everybody, when you start them on buprenorphine or methadone, is gonna never use drugs again. And that's fine. I think the goal is to help them use fewer drugs and help them use drugs in a safe manner so that they don't die. Because truly, the majority of people, no matter what you do, are going to get better, right? But they won't if they die. And so keep them alive and helping them sort of move towards that left-hand side of the spectrum to make healthier choices is incredibly important. And people that get harm reduction services and compassionate care are far more likely to recover than those who don't. And so what is harm reduction? So harm reduction is just based on the idea that people who use drugs have a legal and human right to receive the standard of care including these medications and effective pain management. And I think the thing that I want to highlight is that people who use drugs are people, and that they have a legal and human right to receive these medications, and that is the standard of care. Uh, and so I think, just because you put a substance in your body that I wouldn't put in my body doesn't mean you're any less worthy of receiving care than anybody else. So I think part of the problem that we have now is that we do have all these great tools, right? There's lots of naloxone available out there. Buprenorphine works really well. We're hoping that access to methadone expands. But everybody's kind of waiting for an addiction medicine specialist to kind of take the ball and run with it, and I think, and I just don't think that's going to happen. I mean, I think that this problem has certainly outgrown the number of addiction medicine specialists that are out there, but especially when we're talking about adolescents, it's outgrown the number of addiction medicine specialists that are trained in adolescent medicine or pediatrics, right? Less than half of them get any training in this population. And so I don't think it's enough to wait for somebody to come along and help us out. We have to be the ones that are doing this. And I would point out to you that if you're a primary care physician, or if you work with adolescents really in any setting, if you're a parent, you already do harm reduction, right? I mean, but we call it in medicine, we call it secondary prevention. In parenting, we call it picking the lesser of two evils, right? But we already do a lot of this, right? When we talk about sex, when we talk about driving, we talk about alcohol, talk about smoking or vaping, we say, hey, look, if you're gonna have, like, you shouldn't have sex, but if you're gonna have sex, use a condom. Don't get an STD. Don't get pregnant, right? Don't drive with people who are under the influence. Don't drive with a whole bunch of friends that are being crazy and, throwing things around in the car. If you're going to drink, make sure that you have a ride. Call me. I'll come get you, right? These are all harm reduction strategies that we use as providers, that we use as parents. And so this is not something that you don't have the skills to do. This is something that you're already doing. And so I want to just offer some examples of how I usually approach this. And I'm not claiming to have any, I'm certainly not the expert. This is not a comprehensive list of the ways to do this. These are some of the approaches I've used, and sometimes they work and sometimes they don't work that well. I'm going to give you a few other resources here in a minute. But, if I am just kind of having a screening conversation with a kid that I'm seeing, I would say, hey, do you know any kids that smoke? Do your friends smoke? Have you ever tried smoking? What do you think about smoking? And then I, usually move on to alcohol and drugs. Sometimes we talk about sex in that same way, but just starting with this sort of non-threatening, like, do you know anybody that's doing this? And what do you think about it? Do you have any friends that are doing this? Because if they have friends that are doing it, they're way more likely to be doing it as well. And I would say that, if they do know kids that use opioids, or if they do have friends that use opioids, that's a great spot to sort of jump in with the, have you heard about naloxone? Would you be interested in carrying naloxone? If one of your friends overdoses, you would be able to save their lives, right? And I think, have you ever seen anybody that overdoses? What do you know about overdose? Those are great kind of screening questions to kind of open the door to this discussion. And I think giving somebody naloxone so that they can be empowered to save one of their peers is a big deal. And really makes them feel good. I think, kind of taking a motivational interviewing approach, right? If you find out that somebody's using drugs, I just say, like, how are you feeling about your drug use? Right? Like, I'm not going to jump on them and say you shouldn't do that, because that's not going to help. They're super, at this point, if they have revealed that they're using drugs, they're in a super vulnerable position right now, and they're just waiting for you to jump down their throat. And so I think it's really important to not do that, because then it's over, right? And you've missed your chance to really intervene. And so if they reveal they're using drugs, say, well, so tell me about it. Like, what are you using? How do you feel about it? Are you happy with how it's going? Right? Like, is it all fine, or do you feel like it's getting in the way? Is it making it hard for you to, like, keep up with school? Is it causing problems with your relationships? Are you super nervous about anybody finding out about this? Is that causing some stress? And that gives you an opening then to talk a little bit more about it. And hey, we have medicine for this that will let you cut down on your use. Yeah, and so I think that's a fairly effective strategy, and a really kind of non-judgmental way to help them lead the conversation. think if that's not working, if they're like, hey, I feel great about my drug use. In fact, I want to use more drugs, right? Because that could backfire. You say, well, I'm pretty worried about some of these things that you're telling me. Let me tell you why I'm super worried, and then you can tell me what you think about it, right? And you can talk to them about the risks of overdose, the adulteration of the drug supply out there, right? I think in Seattle, something like 96% of whatever you think you're buying off the street is fentanyl, right? And so, if you think you're buying Xanax, it's fentanyl. If you think you're buying meth, there's fentanyl in it. I've had people that I've woken up with Narcan that swear they were just smoking a hand-rolled cigarette that somebody snuck some fentanyl into. And so I think having that conversation, say, look, most of the kids your age that die of overdose, they've only used once or twice. Uh, and so I'm super worried. What do you think about that? And at least opening the door, right? But again, if you kind of come at them with a you shouldn't be doing this, um, or come at them in a judgmental way, then that conversation's over, and the chances of them coming back to talk to you about this again are are really pretty much zero. So I think it's really important to be open, accepting, interested in, approaching this from a place of curiosity. Like, I want to know more about what you're doing and why you're doing it. And not from a, hey, I'm going to tell you what you need to do. That is, I think, super important. And then you can also approach it from sort of a public health standpoint. And I think that if you're worried about that they might be using drugs and they're sort of not copping to it, I think it's fine to just say, hey, look, overdose is becoming a huge problem. We've had kids in this community die of overdose. Have you heard anything about it? Tell me what you know. And then that can lead to it. Would you be interested in carrying naloxone and learning a little bit more about naloxone in case you run into somebody who needs it? And I think that's another good approach. And naloxone really is kind of um, a door opener, right? It's like a gateway drug. And so if you can get people interested in naloxone, then maybe they'll be more interested in hearing about buprenorphine if you feel like that's appropriate for them. I think including parents is also super important. Kids, if they have opioid use disorder, are going to do a whole lot better if they have supportive parents that are in this with them and willing to do the hard work that it's going to take to get them better. Um, but having said that, kids over the age of 13 have the right to do this confidentially, right? They have the right to seek treatment for opioid use disorder and to get Suboxone prescribed to them confidentially without their parents' involvement or consent. So hopefully the kids are okay with including the parents in the conversation. I think talking with the parents about how you are genuinely concerned about how this is a risky thing with a real, like, honest to God mortality associated with it, but how it's super treatable with medication, but the medication takes time. There are going to be bumps in the road, and that there's things as parents that they can really do that they're going to help, like being supportive, like helping to get them hooked up with, um, you know, drug treatment, plus minus counseling, and then there's things that they can do that are not helpful, like yelling at them, or, uh, you know, making them feel bad for making bad choices. I think, again, kids are really looking out for that. And but kids, they really do listen to their parents. And I think kind of emphasizing that with the parents that, hey, look, they're going to listen to you. If you tell them this isn't okay, if you tell them that you love them, if you tell them that you're here to help them out, they may not always seem like they're hearing it, but it's, at least some of it is getting in and sinking in. So if the parents can't be involved because the kids don't want them involved, then again, I kind of turn back to the public health approach and say, hey, look, I've just been talking with your son or your daughter. They're doing great. I would be interested in sending you guys home with naloxone because of the number of overdoses that we're seeing in the state or in the community. We're really recommending that everybody has this and that everybody know how to use it. Let's take 2 minutes so I can talk to you about naloxone, just from a kind of a public health standpoint. And I think that's a good sort of approach to take it. I would get the kids' permission before I do this, but that's a way that you can try and get naloxone into the household without sort of outing the child for using drugs. I want to just put this up here. I've got the website at the end, but this is a really great website, Washington Friends for Life. that have some super PowerPoints and handouts on how to have conversations with your kids, whether they're in middle school or high school, around fentanyl. Has a little bit in there about naloxone, and it's got, there's kind of a talking points in a slide deck for educators, and then talking points in a slide deck for parents. I think it's a tremendous resource, and I'd encourage you to check it out if you're interested. And so, how can you become a harm reductionist right now? I mean, I think that you all have the tools, right? The biggest thing is the non-judgmental discussions, right? Approaching this from a place of curiosity and sort of mild concern, but not freaking out, not making people feel bad about the choices that they're making. I think asking people how they're using drugs, we would really rather have folks kind of taking, if they take things orally, they're a little less potent, and there's fewer kind of damaging things that happen, rather than inhaling, where they get a much bigger hit. And inhaling is better than injecting, where they're putting themselves at risk for endocarditis and other severe infections. And that's much better than muscling, where they really get deep muscle infections and NSTIs and abscesses and things like that. Safe use kits are now legal. They can get those from any kind of syringe service program or needle exchange. They often include pipes if folks would want to smoke, and we'd rather have them smoke than inject if they're insisting on injecting. And most adolescents don't like injecting, thankfully, but if they're insisting on injecting, they have clean needles and works there so that they don't get HIV and hepatitis C. In one study in New York from like 2018, something like 12% of kids got hepatitis C over just 5 weeks. And so, I think these safe use kits are really important for a lot of different reasons. And, syringe exchange programs are reputable places to learn about how to use drugs without hurting yourself, and do it as safely as possible. And I think just providing facts, like we talked about today, some of the facts that were in the presentation are really important. And just being open to, hey, look, like, let's just keep talking about this. I'm not going to judge you, not going to make you feel bad. I'm here to help. So, let's just keep talking about it, right? Even if you can't get them to get interested in buprenorphine right away, if you can just get them to come back to your office, that's a big win. So I would give out naloxone every chance you get, as much naloxone as possible. There's some good studies from Massachusetts to show the more naloxone you get out in the community, the lower the rates of overdose deaths are in that community. And so, I give it to kids that drink, I give it to kids that smoke, I give it to kids that, that really do any, like, I need the tiniest excuse to give it to kids and their families, because it's so important. And again, kids are the least likely group to get naloxone in the event of an overdose. I used to have to encourage people to get waivers for buprenorphine, but not anymore. If you can prescribe, Norco, you can prescribe buprenorphine now. You don't need to sign up for anything. You don't need to put your name on a list. You don't need to email anybody. You can do it right now. And so I would encourage you to learn more about buprenorphine. The Scala Northwest website will have tons and tons of information on there for you to use it. But remember, every 3 people that you put on buprenorphine, you save 1 life, and that is a big deal. There's no other medication that you prescribe that is that effective at saving lives. And then know your community resources for harm reduction. And unfortunately, it's pretty hard to include all of those in a talk like this, but there's lots of them out there. This is so important because these kids really need somebody, right? They need somebody in their corner. They need somebody that's going to, be there just for them, not for anybody else. They need somebody that knows them, that's compassionate, that's non-judgmental. They can help with some of the other things that go along with drug use, right? Like 41% of the kids that died of overdose last year or 2 years ago had a concurrent mental health problem, right? So a lot of these kids have comorbidities. So they need somebody that can help with that. They need somebody they can talk to as they're starting their medication. They need somebody who is aware of the kind of the milieu that they sort of exist in, right? Like what's going on in the community, in their neighborhoods. They need somebody that really cares about what's going on in those places. And they need somebody who's maybe willing to do something they're a little bit uncomfortable with in order to save their lives. And so I guess what I'm trying to say is they really need a primary care physician that's compassionate. And you, if you're listening to this talk, are ideally suited to do this. So A couple of questions I get all the time that I think we've addressed a lot of these. Can I treat children without parental consent? Yes, anybody over the age of 13, but it's of course a lot better to have parents involved. And I think you can offer to sort of referee that conversation. Do you have to be 18 to carry naloxone? Nope, it's over the counter now. Anybody can carry it. Do you can I give buprenorphine to someone who's under the age of 15, even though it's only FDA approved for 16 over? Of course you can. It's an off-label use, but it's totally legal. We use medications in off-label ways all the time. And so nobody's going to come after you for that. And I will say also that, this is hopefully going to become the standard of care in the state of Washington. And so I would encourage you to really think hard about doing this. Is it hard to sign up and get buprenorphine? I think we already addressed that. You're ready to go right now just by virtue of the fact that you're watching this talk. And what is Washington's Good Samaritan law? And so 48 states have Good Samaritan laws that I think it's helpful to talk to your patients about. Right? So if somebody's overdosing, they can call 911, and the Good Samaritan law says they can't get in trouble for having drug paraphernalia around or being intoxicated. They're protected from prosecution or getting in trouble if they call 911 in order to save somebody in an overdose. The exception to that is like if they have an outstanding warrant for their arrest, then they could get, the law officers can serve that warrant. And so I think that's probably important to point out. Hopefully not many of them are in that situation, but there is an important exception to that rule. I think that the point is that you want people calling 911 when there's an overdose. It's great to give the naloxone, and they should do that. But the naloxone may not last as long as the drug that's causing the overdose. And so they really need to be seen and evaluated by a medical professional. So it's really important for them to call 911 after using naloxone. All right. So a couple important resources. I want to leave this slide up here for a minute. Scala Northwest is going to be launching kind of early to mid 2024, and it's going to have a ton of really great information on there for people that are interested in prescribing buprenorphine and helping their patients, whether they're adults or teenagers, get started on buprenorphine. For the kind of harm reduction approach, there's a national hotline called Never Use Alone. I've called them. They're amazing people. And what they're there for is if you have a kid or an adult who is using drugs by themselves, then they can call this number and somebody will stay on the phone with them the whole time. And if they stop responding, if they stop answering when people say their name, then they'll dispatch an ambulance to their location. They don't have to give their name. It's totally confidential. They do have to give their location. But otherwise, they're so excited to get calls from people and to be able to help out. I think that actually one of the harm reduction things to talk with kids about is if they're using, they should always use with somebody else in the room, somebody who is not using, or that they can take turns using. And, like I would use, and then my friend would wait 10 minutes. And if I'm still breathing, then they could go ahead and use, right? But we have lots of naloxone with us. Everybody knows how to use it. And that's also kind of a harm reduction approach to using, is taking turns. The Washington Recovery Helpline is an amazing resource as well. They have a website that's got an MOUD locator. And so if you don't feel comfortable, treating your patient for buprenorphine, they'll point out places in your neighborhood where kids can get help with MOUD. They do both methadone and buprenorphine there actually, and they it's this MOUD locator. You'll find places for adolescents, for pregnant people, for veterans, for minority groups, for people with any kind of insurance. It's a really amazing tool. But the most amazing part, the secret sauce, is really the people that answer the phone. And so, I have used the tool, but I prefer to call because the folks on the other end of the phone are amazing at finding a tailor-made treatment solution for you or your patients. And so I would encourage people to write that number down. The Washington Friends for Life is the conversation guides that I mentioned earlier. There's the link to that. The UW Psychiatry consult line is for providers. And so if you are trying to get somebody started on buprenorphine, you're trying to adjust their buprenorphine, you can call the UW consult line. It's a 24-hour line staffed by attending psychiatrists, and they can help you troubleshoot and talk you through things. and they're also super amazing people. And then the UW telebuprenorphine hotline is now live as well. And that's really for patients to call. And so that's for people that want to get started on buprenorphine, that, that haven't been able to get it through other means. It's really set up for King County residents, but we can really talk to people and prescribe for people anywhere in the state of Washington. And so if you have patients that, you talk to them about buprenorphine in your office and they're just not interested, they don't want to do it right now, give them that phone number and they can always call 24/7 and get a hold of somebody that can help them out. So, all right. So the summary here, buprenorphine is safe. It's super safe, even in super high doses, right? If you give people too much buprenorphine, they're going to feel a little bit like kind of just, I don't know, just a little bit off, just a little sluggish maybe, but they're sure not going to stop breathing. And it cuts the risk of death in half. Naloxone saves lots and lots of lives, and naloxone is a gateway drug. It encourages people to learn more about drug use. It encourages people to get into treatment. And, the more you can get out into your community, the more lives you're going to save. Every day that somebody takes buprenorphine and has those receptors occupied by buprenorphine is a day that they can't overdose. And so please, please, please consider prescribing buprenorphine. The ultra summary then, sort of the next level up, is that OUD is a big deal among adolescents. It's happening all over the place. It's happening in your neck of the woods. It's happening in my neck of the woods. You are more equipped to deal with this than you probably thought you were, right? You have a lot of experience with harm reduction, with secondary prevention, and you have that whole toolbox that you can apply to this situation. With the deregulation of buprenorphine, we have the things that we need to really stem the tide of these rapidly increasing overdose deaths among adolescents. Like, we have the stuff, we know what to do. We just need to use it. We just need to apply it. We need to get it out there. And so I think the mega summary then is that there's only two ways you can screw this up. One is by not trying and not engaging. And then the other one is by being judgmental so that people don't want to come back to you because they feel judged. So don't be afraid. Give it a shot. There's lots of resources out there available to help. There's people standing by 24/7 to help you do this and do this right. But your patients, your kids, they need you to do this. Nobody else is coming to help, right? There's not enough addiction medicine doctors out there that do adolescents. And so whether it's unfortunate or fortunate, we're the ones that we've been waiting for. So thank you so much for sticking through this whole presentation. I am super happy to talk with people some more if you want to reach out by email. Hopefully these resources are helpful, and good luck, and thanks for the hard work that you're doing. All right, take care.